to talk about localization and locking of the lumbar spine. You'll find this in the Level 2 lower clinical manual. 2010, that's page 41 to 42. The purpose of trying to lock the spine is, the approach is to try to isolate the segments that we're trying to work on. The treatment segment is always going to be held in that neutral position, at least until we take up the barriers that we're going to, depending on the treatment we're trying to create. But for our purposes of trying to understand locking, let's think that the segment, the treatment segment, remains in neutral. And the segments that we're locking are the ones that are caudal or cranial to that segment. We use locking to also reduce stress that we'll be pushing through the spine when we place our forces. Depending on the grade, the higher the grade, the more we have to sort of protect of reducing stress. Focusing our treatment to that segment, locking is essentially what's going to help create that, and in effect reduce our overall force that we need to put through the segment. In the lumbar spine, we essentially have two types of locking that we're going to use. Facet locking tends to take place above the segment, and physiological locking will be taking place below or caudal to that segment. We're going to first talk about the facet lock. It can be done in either a contralateral or ipsilateral fashion, in an ipsilateral way. Ipsilateral coupling is side flexion and rotation to the same side. Contralateral coupling is side flexion and rotation to opposite sides. When we use the facet lock, we may very well also use some combination of flexion and extension, again to sort of create a tighter lever so that we will be able to direct our treatment forces appropriately and safely. Many things that you have to consider when you're going to think about locking the spine. First off, of course, the level. So being local to the treatment that, being local to the segment that we're trying to treat is very important. Comfort of that upper lever into the thoracic cavity, chest area is paramount, as well as the lumbar spine, and making sure that there's good comfort in the lock that we choose. That will be always one of the guiding principles of how we're going to use locking. If it's indeed uncomfortable for the patient, then it's not going to be very useful as a treatment process. We need to understand the mechanics of the lumbar spine, and certainly in the Level 2 course we're going to do more discussion about that and think about how the spine moves. The guiding principle in the lumbar spine is research really tells us that the coupling pattern, the conjunct coupling pattern, is variable. So we're not really going to talk like we do in the cervical spine about incongruent and congruent locks. We really are going to reserve our discussion to be talking about contralateral, ipsilateral coupling patterns, because indeed there's such a variety or a variability that's going to take place in the lumbar spine. So to avoid confusion, it's probably useful for all of you to consider when you're in the lumbar spine to be using the terminology of contralateral and ipsilateral when we're talking about the cranial or facet lock that we do. Things that you need to consider also relates to hypermobilities. So this is one of the reasons why we're going to use locking, is to protect. And when we have determined through our examination that there's a hypermobility in segments above or below, we're going to use the positions we place patient in to avert any discomfort or any safety considerations when we're doing these kinds of treatment. So this is the thoroughness of the kind of examination that you're going to do is paramount. And when you start to use higher grades, certainly in manipulation, these considerations become even more important. So the grounding of this information is very important at this level. We need to think about the pathomechanics of what occurs on assessment. So your assessment and what is causing the issues within that spine, what's the structure at fault. These are important considerations. One example could be if a patient had a disc problem when there was a protrusion above a segment, and you would want to be considerate of the dimension of the intervertebral foramen. So understanding the pathomechanics of what's going on will also help determine what kind of locking you're going to use. Sometimes we want to consider which combined movements produce the best motion barrier. And because there's variability in our patients, you may use a contralateral facet lock above, but decide that it doesn't produce a firm enough lever for you. We want you to have the flexibility of just changing your mind and then turning that into an ipsilateral locking pattern. So you want to think of the combined movements and which one produces the best stiffness in that segment that you're trying to use. Something else that you want to consider when you're locking is the motion that you're trying to encourage at that restricted segment. For instance, if you were trying to improve flexion at the treatment lesion section, it would make sense that the lower lever, you may pull it into a degree of flexion because you're going to be going in that direction anyway. Be careful of that consideration. What will always trump the biomechanics of what you're trying to encourage is the safety and the comfort of your patient. So don't allow yourself to be rigid in your approach. It's a consideration when you're trying to use locking, that motion of what is encouraging that segmental movement, but it should not always guide you in sort of a dogma kind of way. Shortly, we're going to sort of talk about the positioning of what of how we go into locking. So in your notes, we're going to talk about the position of rotation, how to position someone towards extension, flexion, how to do contralateral and ipsilateral motion. And we'll do that in a practical sense when we get to that section. The ligamentous lock that is typically used below, in a lumbar spine, we typically use flexion. A consideration that isn't in your notes is that we can also apply a degree of side bending, which again is a physiological motion. We might not then term that as a ligamentous lock. We usually are talking about flexion when we're starting to use, when we use that term. So it's a convention that we tend to use in the lower quadrant, but again, use all of the considerations I spoke about before on how you should use locking. In a couple of seconds there, we're going to divert into the practical part of this, and we'll see how that works out.